Let's see how many people are here. Good morning, everyone. Just holding on a bit. People are just coming in to the room. I hope they're hearing me. Dr. Hylton-Kong, you hearing me?
Yes, we can hear you fine.
Okay, great. Hello. Hello. Mhm. Mhm. 24 people. Dr. Kong, I think I'm going to start.
Okay.
Yeah, but there are only 27, there are only 26 people, but I don't know if we should wait a little 2 minutes again and start at 10:35. Give people a chance to come in. I have some competition with rain,
Oh, okay. And
so in
football?
case, and football. Yeah, I'm just trying to keep check of I'm trying to keep check to see how many people are joining. Mhm. So we now at, let's see, 25. Just put a message in the chat. Okay, I think I'm going to start. I think the others will join as they come in, right? We have 25 persons. So, I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will go ahead and join and start. 25 persons. So I will
So I'm to go ahead?
Yes, I'll go ahead and start.
Oh,
So,
okay.
so good morning once again to everyone. And it is with appreciation that I welcome you to the webinar today. Today's webinar is a continuation of the last training, which focused on syphilis during pregnancy. But before we continue, I would like to remind you that the webinar today is part of a series of training organized and implemented under the project, which is funded by the Indian Development Partnership, the strengthening of EMTCT services within maternal and child health services. I know many are interested and excited about this topic today, so we take this opportunity to welcome back again Dr. Tina Hylton-Kong to the session. I know at the last session, there was a lot of enthusiasm, a lot of questions, and I did share with Dr. Hylton-Kong some of the areas that you would like to hear a little more on, and she has agreed that she would include it in her presentation today. So what is going to happen is that we are going to focus totally on presentation and the questions and answers. Well, as you all know, Dr. Hylton-Kong has many, many years of experience with syphilis in this region, and we are happy that she has taken time from her busy schedule to facilitate this session this morning. Just before we start the session, I want to remind you that the mics are muted. Please feel free to put your comments and your questions in the chat during the presentation, and they will be addressed after the presentation or during the time designated for questions, and all at which time the mics will be open. So now I would like to hand over to Dr. Tina Hylton-Kong to take us through the session today.
All right. Good morning. Thank you. And I thank you for your patience the last time when we had some hiccups. And hopefully things are running much smoother this time. Thank you again for your attention. And I do treasure the participation. I think that's what really made the session last time worthwhile, your participation and your questions, because, it is a difficult topic. And the questions, even they're not always answers, but the thinking through is what we can do together. Thank you. And I hope you're hearing me okay and seeing the slides. I'm going to show you the outline
I'm going
slide.
to
And it
mute
has
my,
this.
my computer because the rain is pounding.
I didn't get that.
Proceed, Dr.
Okay,
Dr.
and you're
Hylton-Kong,
seeing the
proceed.
outline for today that we will review the diagnosis of syphilis in pregnant women. Let's talk a little bit again about interpreting the maternal syphilis test results, review the management of syphilis in pregnant women, and review the diagnosis of congenital syphilis. Identify infants who meet the criteria for being syphilis exposed, and determine appropriate evaluation and treatment regimens for exposed and infected infants. I want to say I'm not a pediatrician. I can only sort of give an overview guidance and on this. And so there are going to possibly be some questions that I will have to pass on to the experts. And just a few in discussion regarding principles. So just to give this overview that we know syphilis is a major public health problem, and hence this is why we have these sort of discussions, and that in the worldwide, it seemed to have been having some increased cases. I know here in Jamaica, we are also a bit concerned with some increased cases. And despite all of that, and probably in spite of all of that, over 20 countries have been validated for elimination of mother-to-child transmission of syphilis. But of course, that's only part of the story. You have to be recertified. And so Jamaica is should be recertified next year. And so we're being prepared because we are kind of worried about the increase in cases too. So you always have to be actively maintaining it. Most infections occur in the developing world, Latin America, Sub-Saharan Africa, here in the Caribbean, Southeast Asia. And that untreated syphilis in pregnancy is associated with too many heartaches, spontaneous abortion, stillbirth, perinatal death, premature delivery, low birth weight, and congenital syphilis, which in most cases is really a very high morbidity and mortality. So it really it's something that we really want to prevent. So we know that this is just kind of reviewing. The organism is Treponema pallidum. It's a bacterium of the spirochete family, and it is spread by sexual contact. The treponemes actually penetrate intact mucous membranes, but it cannot really penetrate intact skin. So it's usually through skin, minor cuts, abrasions, and so on. And that is likely to happen at any sort of area for sex, because usually there is some sort of, mild trauma and so on. And it can also be transmitted by vertical transmission, and we know that is mother-to-child transmission, and rarely through blood transfusion. Most blood, I would say all blood transfusion services test for syphilis, both the treponeme and non-treponemal tests. But of course, just like with window period, this can happen. So the primary stage of syphilis, that's the first stage, and usually that occurs with a painless chancre, with that indurated, punched out base, and rolled edges is a typical presentation. Usually one or two, or not multiple, like many, but a few, or single, and usually occurs at the site of transmission. So if there's a chancre at the mouth, that was where it had the sexual contact, the anus and so on. So that's an important aspect to know. That's the only situation for this stage, is the only where it occurs at the site of transmission. And it can occur, there's an incubation period of 9 to 90 days, average about 21. So if when we're thinking, and that many are unnoticed, especially in women, and up to a third may not notice, or it's so mild, painless, it heals on its own, it's maybe happening 3 months after. Can you imagine the difficulty of getting that history from the patient? So that's why we really have to be probing a bit and asking the patient, but it's going to be difficult to bring to memory for many of the patients. So nothing is, a picture is worth 1,000 words. So I just decided to take some of the pictures from off CDC's training cards to just show you that primary syphilis can occur at the site of exposure. So the mouth, which that could look like you had some hot tea that morning, and it could easily. It seems very circumscribed and differentiated, so that might be a clue. And that is painless. It can be on the cervix, and so we really need to clean the cervix, mop the cervix, so that we can see what is there, what's on the os, what's coming from the os, or what's on the cervix itself. And the other picture there in the lower border is of the perineum in the female, and you see 2 distinct ulcers. Those have the classic presentation, that rolled edge, clean base, and that would be painless. So this woman could be presenting for her pap smear, and you asked her if she have any problem, and she told you no. And then you have her on the bed lithotomy position, and you see this, and you were like, didn't I ask this lady? But she obviously may not, because it's painless and did not know. And of course, you have to look carefully to see that you may have an ulcer there in a perianal region, whether in a male or a female. So this is important, because many times, for us to stage syphilis, we need to make sure we have a proper exam. And many times we do not examine thoroughly the mouth, or, sometimes even the genital area. And for the secondary stage, so the person will have had syphilis, primary stage it resolved on its own, and then over some period, they may then present with secondary stage. And sometimes it will resolve and come again. So there have been occasions where you would have an intermittent presentation of secondary syphilis. And it's the great mimicker. So it can look like liver spots, it can look like prickle heat. It can look like wales from allergy, that what looks like when, you have eaten something or taken allergy and get the wales. I've seen it even looking like psoriasis. So you really can trick you. It involves the organs too, the kidneys, liver, central nervous system sometimes, and they may have constitutional symptoms, fever, tiredness, lymphadenopathy, something similar to some of our viral exanthems that we may see, and alopecia. So you have to be thinking it's going to be your history of the person's risk and so on that's going to clue you in. So persons with, with syphilis, usually there is someone in that network, sexual network, that is high risk. So it may not be the patient themselves, but some contact or a contact of a contact. And so it's different from, say, herpes, which is very common. It doesn't have to be very high risk sex to get herpes, sort of thing. But syphilis, it would be a little bit more in that category because it is, though we have increased cases, not as widespread as before. So there was a time when syphilis was really like in terms of, say, herpes too. So, but now it is much less. So when we see it, we know that someone in that circle, there's high risk. Okay. And of course, the latent stage, there are no signs. Now, many times I can imagine we would have called a latent stage because we did not examine properly or we missed some of the signs. So we have to be cognizant of that. And it's early latent if it occurs, the person has, so the only thing is that they would have had a reactive syphilis test. And if the reactive syphilis test is within 2 years of having a non-reactive, then we call that early latent. Oftentimes we don't have any previous results of the person, so we are on the safer side to say it's late latent if we have examined or the history didn't imply something very, at risk early. All right. And these are some of the signs that you may see. As I said, multiple signs and many different presentations. I want to highlight this one of the rash, though, that even in this picture, the center has a very high light source. And so sometimes if you're just looking quickly, you may not see, especially if your light source is not sort of dim, because if you look towards the side, you see the rash appear much better. And I certainly experienced that in my time as a younger doctor. And Dr. Alfred Brathwaite, I had asked him to come and help me see a patient. And he came and just tilted the windows up and wow, I just saw that mottled appearance so quickly. So it's important to know what we're looking for. The hair loss, it's a patchy alopecia, they say kind of moth-eaten. So you see that sort of patchy, not a circumscribed, distinct area as in other conditions. And the palmar rash that can occur, or the last picture there is a condyloma lata, or these moist sort of raised lesions. They will occur anywhere that's moist and warm. So you can have it in the genital area, you can have it in the axilla, you can have it under the breast, anywhere that's warm or moist. So that's something also to note. Has anybody ever seen condyloma lata or any of these secondary stages? Anybody has ever seen? Okay. And I recently was doing some sessions for Ministry of Health, and one of the doctors told me they saw a case with loss of the eyelashes. So as I tell you, every now and again, we're going to have some unusual presentations. I saw loss of the lateral aspect of the eyebrow once. Okay, and then of course there are this tertiary later stages, tertiary stage, which presents as gummatous disease, which can be on skin or internal organs. And you can also have cardiovascular disease leading to, inflammation of the aorta, even dilatation of the aorta causing regurgitation. You can have narrowing of the coronary artery openings. So that's one of the workup. Good thing that, syphilis is one of a screening tests for many diseases, dementia, heart issues, mental health, what do you call it, autoimmune diseases and so on. So it's important that at least we are screening, but we want to get things earlier. We don't want to be having to wait to these late stages. And there is neurosyphilis, and neurosyphilis can occur in early stages and late stages. But like, for example, in secondary syphilis, you can have it affecting the optic nerve, causing papilledema and so on. So we are to be mindful of that. What we need to know about syphilis, which is also very important, is that the longer someone has syphilis, the less infectious they become. So if we see someone with, say, tertiary syphilis, they're not likely to be able to spread it except through, blood. And so we wouldn't really like, be using all of our hard, hard to find partner services for that person necessarily. Certainly for a pregnant woman, any stage of syphilis, but our efforts would be intensified for early stages of syphilis. So primary, secondary, and early latent are considered early infectious syphilis, and they're highly infectious. But the mother to child transmission can occur at any stage. Sure, if mom had a later stage of syphilis, then it is less likely that she'll pass it on, but she can. So the longer mommy has syphilis from before pregnancy, the less likely she will pass it on, but it can. And the risk is higher for women who present later in pregnancy, as some of the concerns that was shared with me in the concept note, having you completed the evaluation. Many of you said, what do you do for the mother who just came in late or didn't come for antenatal? So that's also a common risk scenario. And the mother to child high transmission will also occur. It's going to be highest if mom has infectious syphilis. So whether primary, secondary, or early latent, that risk of transmission to the baby is much higher than if mommy had late latent syphilis. Mother to child can be prevented, and that's why we're even eliminated, and that's why we're continuing with this effort. The outcome in pregnancy, during pregnancy, is if someone has primary or secondary syphilis, most of those babies, 100% premature delivery or perinatal death. If they have untreated early latent, that percentage will fall to about 40%, but still very high. And note that only about 10% of those with early latent will show signs of congenital syphilis ever, right? But the large, and we may see also evidence of syphilis in the during the delivery. We notice a large pale placenta, and if it was unfortunate that they had stillborn or so, you would see that the fetus may be macerated. Or if, sorry, earlier, then it would be fetus would be macerated. So the postnatal, it would be stillborn, as we had said, premature delivery, or the child can be born with congenital syphilis. Not common to have those signs at birth, but if you do, it's also a poor prognosis. We had a case in Jamaica, and it was really, we didn't, it was missed. That's a long story, but basically, it's also because our clinicians had not seen it for a while and not very aware. So this is why we were also increasing our awareness again. Born, or the child could be born with latent congenital syphilis and develop the signs 3 to 4 months or 6 months later. Or they can then have the congenital syphilis as latent and develop signs over later than 2 years. Or they can have, just like in adults, someone can have syphilis and be latent, meaning no signs or symptoms forever. But in children with this would have a decreased life expectancy. So we have 2 stages of congenital syphilis, early or late. And early is within 2 years of birth, and late is after 2 years. If we do have signs of congenital syphilis, they are going to be likely to be bony lesions, and the bony lesions specifically are like the periosteal reaction. So the periosteum, the covering of the bone, gets inflamed. When you look on those x-rays of the long bone, humerus and femur, you see like a extra line, like a double line, whitening, so that's showing the periosteal reaction. So pretty easy to do. In fact, the baby might be very tender. You hold that baby, the arm, or the legs, they will be crying. The rashes, up to 60% of cases, and the generalized lymphadenopathy. They also make note that many will have an epitrochlear lymph node. And so sometimes, anytime you feel an epitrochlear lymph node right by the elbow there, even in adults, that's significant. So it's always a good thing to check out. when you're doing a quick examination. The child may have hepatosplenomegaly, sometimes not very obvious, so sometimes they need ultrasound to help to look at that. And of course, central nervous system involvement. Remember this, the congenital syphilis can also cause failure to thrive, sepsis and these other sort of general symptoms. So we always have to be looking for it. And as well as said, many will have no signs. The respiratory signs, the snuffles, the sort of thick nasal discharge that sometimes can become bloody, and in some instances they get this pneumonitis. When you take an X-ray, the whole lungs are white, and that is very fibrous, difficult for any kind of respiratory support. Those rashes, by the way, are extremely infectious. So, we have to know what you're looking at. You may think, oh, this is some Lunago. So, no, you have to really be very astute and have your high risk of suspicion as well as, standard precautions. So late congenital syphilis as latent, can at birth, 50 to 90% of infants born with syphilis are asymptomatic. So this is why we really have to focus on prevention, and that we also have to focus on what is the status of mom's test and treatment. The signs may take months to develop, and they may be vague or mimic diseases posing a challenge. So just as with adults, if you think about it, the baby would have got infected during the pregnancy, and so 3 months after, which is like the incubation period for the primary syphilis, they may have a lesion. And so that lesion can actually occur. Suppose mommy had syphilis, primary syphilis during pregnancy inside the vaginal canal. No one noticed, and baby was born, breech, and you see 3 months later, you see a baby with an ulcer on the feet. That would be a primary syphilis, but it's really congenital syphilis. So similarly, they can have the secondary signs, within that 6 months, 3 months, 6 months after, and so on. And symptoms, if untreated, then of course the sequelae, well, that's not how you spell sequelae, may take years to develop. And this is the late congenital syphilis. We don't see much, thank goodness, but I'm sure we may have missed. But these are some of the classics. So again, our dental team are going to be important stakeholders in our elimination of mother-to-child transmission as well. This would be a later stage, but I mean, for even the mothers and or general population, going to the dentist, having these oral lesions, we need to also be screening for syphilis. All right. I think the more common that we see in late congenital syphilis is the eighth nerve deafness. In my experience, I remember it was a child up for adoption, and they routinely screened, and that's how they discovered the syphilis. She was deaf, but they didn't really know why, and then they had discovered that it was syphilis. And so just looking at the indicators that WHO has stated for us to be validated as having eliminated mother-to-child transmission of syphilis, the impact indicator is that you should have less than or 50 or less than 50 cases per 100,000 live births. So, many of our countries, the live births are decreasing. So our denominator is getting smaller. So it would imply that our case rate, we can even be a smaller number to attain that 50 or less, 50 or more over per 100,000. And of course, they are looking at the process indicators. These are just a few, but the mother should have had at least one visit. And 95% of our mothers should have had at least one visit to an antenatal clinic. We know that that's very minimal. Most of us are targeting at least 6 or 7 visits for the mothers. Coverage of the syphilis testing, and many times it's not a problem with the testing, it's the recording, documenting. I'm sorry, I have some birds who are after my puppy's dog food. And they're protesting. So, yes, many times we have the documentation for the HIV test and not that for the syphilis, even though they did the both tests at the same time. So, just to make sure that when we have our documentation, we are documenting both and dating. And the other very problematic is the treatment of syphilis seropositive pregnant women. That should be over 95%. And many times syphilis, the mother may have been treated at a different site from where she was referred and all of that. So we have to make sure it's the documentation at all of the different centers. The diagnosis of syphilis can be very difficult, and because we think we just can diagnose with a blood test, but there is actually no single currently available lab test that can provide a definitive diagnosis. And oftentimes the blood result on its own doesn't really help you. It is very important, but it doesn't. What is the key is your history and having your index of suspicion up. So trying to get a good history. Of course, even that, the approach to the patient is very important. All STIs, especially syphilis, has associated with a high stigma. And so we have to be careful how we are, maneuvering the confidentiality, the non-judgmental approach, trying to make them comfortable, just asking and getting more open-ended, what are their risks as opposed to, do you have this, that sort of thing, or as opposed to close-ended questions. And listening to any symptoms, sometimes probing for those symptoms, as I said, and then of careful examination. Because remember, these, especially say the secondary symptoms, they may be thinking something else totally. Even the doctors may be thinking something else completely different. So it is important that we also try to think of this possibility in our history, but also in our screening for blood tests. So if you have a rash, I think it's a good idea, especially anybody sexually active, to do a syphilis test as well as part of a routine. The serological tests, as I said, they are very important, and we use the non-treponemal and the specific treponemal test. Our treponemal tests are specific for treponemes, not for Treponema pallidum. So if you have any other kind of treponemal infection, pinta, yaws, and so on, then it will also be reactive. The non-treponemal is not specific to syphilis. It shares. It's a particular kind of lipid that is in the cell wall or in the cell of treponemes, but also part of human and cells. So that's why it's sort of but it's useful in detecting syphilis. And these are faint because these would be more like, very high resource areas or research centers. So dark field microscopy, very difficult to even get the parts of the microscope anymore. And the polymerase chain reaction in many sites with more resources, they are using that for detection of the antigen in, say, the ulcers or the rash. So that would be very useful. And that's very specific, but it's also pretty costly. So let's camp out a little bit here at some of the serologic tests for syphilis. And the blue columns are the treponemal tests. And so you may be familiar with some of those long names, or you may be more familiar with the abbreviation. So Treponema pallidum particle agglutination, you may see that in your lab forms as TPPA. I don't see much fluorescent treponemal antibody absorption. It's a pretty more expensive test and more, difficult to use. We do treponema pallidum hemagglutination. I know in the Bahamas they use enzyme immunoassay, and many parts in the Caribbean we have the treponemal point of care kits, such as the SD byline. They now have 2.0, but they also now have 3.0. So it's a point of care that's treponemal, and we use that in Jamaica in our public clinics and our outreach activities. So we have our non-treponemal tests in the green columns, and you see the one that everyone knows. We know it as VDRL. In fact, we are often using VDRL as just like synonymous with any syphilis test. And so you would say the person had a VDRL when in truth they had a RPR. So it's very important that we be specific about that, because it can cause confusion and lead to difficulty making a diagnosis. So We have toluene red unheated serum test. We use that in Jamaica too in our public clinics. Many times the VDRL are more at like hospital centers. It's cheaper, but it has to be done in batches. So sometimes if it is that you're having not much cases, it can cause a delay. So many of the private labs too are now using like rapid plasma and reagent tests. But we need to know what they're using and make sure that's what's on their form. You now also have some point of care kits that have both treponemal and non-treponemal on it. Any questions re the serological tests? Is there anyone else that's used as something else? Oh, the MHATP is also one. I'm not sure how often it's used as well. Microhemagglutination, something, treponemal pallidum particle, something. I'm into abbreviations for the test kits. It's simpler. All right. And according to the stage, the response to the different, this table shows the response to the different treponemal tests according to the stage. So we see that you can have a negative or a non-reactive treponemal test if you have primary syphilis, and you can have a non-reactive non-treponemal test. So the VDRL could be non-reactive and their TPPA could be non-reactive, even though they have a chancre. So again, this is why we can't only depend on blood results. We have to have the good history. We have to have our examination. So that's why blood test augments or the diagnosis, but it's not the be all. And for secondary syphilis, we see something different. It's 100%. But I will challenge that to even say that there are some occasions where you have a secondary rash, even palmar rash, and your test is, well, not your treponeme. Treponeme would be reactive, but your non-treponeme may be non-reactive. And that is, I'm not sure if I had mentioned it the last time, the prozone reaction, where the person has very high antibody level and it interferes with the complex reaction, the reaction of the antigen to an antibody, and so they don't get to form that, and it blocks that formation, so it comes out as a non-reactive. If you see a patient with a palmar rash or some condyloma lata or just generalized rash, which you have that high risk and that you think this could be syphilis, and you ask the lab personnel to dilute the serum and test again, they have to carry it out to the full, I think 50 dilutions if they haven't had non-reactive, if they had non-reactive all along. But usually you find if it is secondary syphilis, then it is reactive, something like, reactive 1 in 512, a high titer, because of, and showing that antibody level is really very high, which is what caused it. But if it's after dilution, it's non-reactive, then think again, your diagnosis is wrong. It's not secondary syphilis. So that's how we would interpret the syphilis results for secondary syphilis, 100% all the time, barring any prozone reaction happening. And then in early latent, you may have a few that are the treponeme and or the non-treponeme are non-reactive. But usually these all stages are early latent, early infectious syphilis. They usually have reactive. That's the more common thing. They are reactive. And the non-treponeme is reactive with a higher titer, like more than 1 in 8. It's reactive 1 in 16, 1 in 32, 1 in 64. 128, 256, 512. So it's a log progression. Anybody have, what's the highest titer? Somebody could just put in the chat, what's the highest titer they have ever seen? Okay, I have to move on though. Let me move on. All right. So when we have a test, we have the treponeme test is reactive. We have the non-treponeme, say the VDRL or the RPR is reactive. Then that means they ever had syphilis. but it may mean that they were treated or untreated. How will we know? From the history and the documentation. And if the titers are more than 1 in 8, say 1 in 16 or more, then it's likely to be infectious syphilis. And depending on if there are signs, primary or secondary signs, then they're primary or secondary. If there are no signs, then they're early latent. So that's how we use the tests, with or along with our history and our examination, and knowing the likelihood, the characteristics of being reactive. If the treponeme is reactive and the non-treponeme is non-reactive, it could still be treated syphilis. Somebody who was reactive 16 got treated and over time has gone down to non-reactive. Or it can be someone who has syphilis, late latent, never been treated, never diagnosed, just came up on a blood result now. They would have the natural progression. They would have in the original in the early episode they would have been reactive if we got them at that time, and highly reactive, but over time it goes to a low titer or even non-reactive. But as we said before, it could also be someone with primary syphilis or very early latent syphilis who the treponeme is reactive, but the non-treponeme is non-reactive. And so the treponeme is the test that is likely to become reactive first. Then the non-treponeme is reactive. Okay? So that's also to be important to note even for our babies. There was a time I was thinking, why do we even need to do treponemal test in the babies? But I've seen where it has some value, especially if you want to kind of, you're not so sure what is happening with the baby. Most important test to do for the baby is the non-treponemal test, but there are times when the treponeme will be helpful. And if our treponemal test is non-reactive and our non-treponeme is reactive, then that's a case of biological false positive, which we said in pregnancy that happens quite a lot. So if we are using an algorithm that uses the non-treponemal test, say RPR or VDRL, we are likely to have some of those pregnant women will be false positive. But many times we will opt to treat empirical, depending on how quick you can get results and so on. We would rather to be safe than sorry, so we may opt to treat that mother. And then when you get later, if it's a non-treponeme, then you can, you say it was false positive. But if you're using the algorithm where you do the treponeme first, they would not be coming up into your group of persons who are going on to do your non-treponemal test. So we would be ruling out some of the biological false positive in that algorithm, which is useful. So some principles to remember: that we compare titers for the same type of serological test. So we don't compare trust or RPR, or we don't and RPR. Say mother is RPR result and baby is in the hospital and got a VDRL result. We can't compare VDRL and RPR. We need to test the mother again using VDRL to compare VDRL with VDRL. All right, important. New infection or reinfection if a fourfold increase in the same test. So if mommy's VDRL was reactive 2 and baby's is reactive 8, that a VDRL2, so that's gone from 2 to 8. That would imply that that baby has syphilis, congenital syphilis, because it went from 2 to 8. If it's 2 and 4, that's not fourfold. Or if mommy in pregnancy was treated and then she went from 4 to 32, then that's a reinfection. So once it's more than fourfold using the same test, then it is infection. And we can't be making diagnosis and so on with a lab that's not practicing proper quality assurance. So we need to know that our test is as good as our lab. So we need to make sure that those things are also in place. Temperatures, the kits and so on, all of those things. Good lab practice, extremely important. As such is also our good history examination and documentation, especially between referral sites too. That's where it's like Chinese telephone. We lose a lot of information from when we're moving from sending the patient from one place to the other. Treatment of infectious syphilis, so that's early, latent, primary or secondary syphilis. We give benzathine penicillin G 2.4 mega units IM stat, one dose, and that will treat mommy from cure her primary, secondary, early syphilis. It will also cure most times cure the baby. So the benzathine penicillin, excellent, it goes across the placenta, so it can treat mommy's syphilis in mommy's blood and go across the placenta to the baby and treat the baby. And it will stay there for a while because remember, benzathine penicillin is around about 2 weeks, 3 weeks sometimes. So it will help to cure any if baby had it. So that's why we would say that's the treatment of choice. That is the one that we know will work. Erythromycin, 500 milligrams 4 times a day for 15 days, only if you have a mother with proven truly allergic and there's no safe desensitization service. So WHO just says benzathine penicillin is the treatment of choice. There's no other choice. And if you have a baby that's treated with erythromycin, they're going to count it as a case. And so we have to see how best we can, one, retrain as to what is allergic, because we do have a lot of persons who we say are allergic, but they're really just fearful. And sometimes I wonder if the healthcare provider is also fearful. So we really need to do that, but also set up sites that we can refer the patient, mother, to get penicillin in a safe place where she can be desensitized. The treatment of late syphilis in pregnancy is the same benzathine penicillin G 2.4, but they get it for 3 weeks. So weekly, 3 times. What if she miss a week? If it's a week, 5 days, 7 days a week, she's on the 8th day, then she probably can come and get it. But if she's coming 9th, 10th, she has to restart. So it really, it's weekly injections for 3 weeks. But, remember that if mommy has late syphilis, that benzathine penicillin, she would have, if it's late latent, she would be having the syphilis in her system. The baby would not be having late latent syphilis. The baby would be having early syphilis because the baby is just exposed to that syphilis germ. And so the one injection, the first injection mommy gets in those 3 will cure the baby or help the baby. So it is important that that's what we count. We count from that first injection, the 4 weeks that we're going to talk about later. All right. So sometimes if really if there's conditions are not completely right or so, just give mommy stat. You can work on her, treating her latent after pregnancy if needs be. I'm not saying that that's what if we can, we do treat her as soon as possible for the stage of syphilis she's in. But we know we give her a stat. That is how we're going to prevent congenital syphilis. And what do we do with mom when she is diagnosed with syphilis and we have treated her? We repeat her test monthly and at delivery, because she can be reinfected. And so we expect a 4-fold decrease in the titer after 3 months if she had primary or secondary syphilis, and after 6 months if the diagnosis was early latent. So as I said, I think I might have said before, the earlier you treat someone with syphilis, earlier in the stage of syphilis that you treat them, the more likely they're going to become non-reactive sooner. So that's why sometimes we have persons we treat late latent, they're so long having the syphilis, even if we treat their titer, may not become non-reactive. It may fall a bit or not, depending on what the titer was. So we want to, how do we identify those babies who were exposed to syphilis? First of all, we want to make sure infant keep a record, have a surveillance to note any infant born to a mother with a reactive syphilis test during pregnancy or at delivery. We're not saying about if she has syphilis. Once the mother has a reactive syphilis test, then we have to be making a note. Find that baby, following up that baby and that mother pair to see what's happening. And the step 2 is clinical and lab evaluation. We'll perform a clinical examination of the baby, make sure there's no hepatomegaly, make sure, all of those things we had gone through, and we would do a non-treponemal test on the baby. And on the CSF, if possible, do a complete blood count, and certainly if we can do long bone x-rays as indicated. Step 3 is stratifying that risk, assess maternal treatment adequacy and the infant signs, if there are any, and the lab findings. So we'll put our information together and decide what we are going to do. The treatment decision now is step 4. If mother was adequately treated and the child is asymptomatic, then we will just follow up the baby. Why are we following up the baby? Just in that slight chance that she did get treatment, but somehow maybe reinfected later on or what, and the baby has early latent. And so that's why we're going to follow up baby till 3 months, maybe 6 months, and so on, until non-reactive, if possible. And if mother is inadequately treated or we have a symptomatic infant, regardless of mother's status of treatment, then we will initiate full course of the aqueous crystalline penicillin or procaine penicillin. It's usually 100,000 to 150,000 crispen daily for 10 to 15 days. And we will have to follow up that baby. Regular serologic tests, titers, and clinical evaluation to ensure treatment success. We'll also be following up the mom too, so that's important. Then treatment of congenital syphilis. Oh, as I said, I had said it before, 100,000 to 150,000. So again, it would be infants with confirmed congenital syphilis or infants who are clinically normal, but mother with syphilis and was not treated, came in very late, or it's suspect that she might have, and inadequately treated, including treated within the 30 days of delivery, or she was not treated for her stage, or treated with a non-penicillin regimen. If you don't have Crispen, which is aqueous benzyl penicillin G, then you can use a procaine pen. This would be 50,000 units per kilogram per day, a single dose intramuscular, 10 to 14 days, 15 days. So we would closely monitor the infants who are clinically normal and the mother had syphilis and was adequately treated, and there were no signs of reinfection, we still would monitor. There's just that slight chance that baby may have it, so we still monitor. If you're not sure that that mom or baby will come back, then you may opt to give benzathine penicillin G right there. But some folks say that's not really too, ideal. But again, if you can't find a mother or you're not likely it's one of these, maybe, a homeless mom or something like that, then you just opt to give the baby. And because remember, benzathine penicillin G is not going to pass the blood-brain barrier. So if baby did have congenital syphilis and develop neurosyphilis, it won't really help. And it may affect the results, and so we may not pick it up. That's really the danger. But the benefit of giving some treatment is if you can't find them, that's, benefit outweigh the risk. So again, sometimes, it's not clear cut. We have to look at all the scenarios. And we'll follow up testing. That's a very important part, because it's in the follow up that we may decide whether we need to retreat or so on. All right, so it's time to breathe and stretch if you have to. Good to stand, so that before we get into the cases. Any questions, comments at this point? I think I'll also take.
Yeah.
Time-wise also, Donna, how am I doing?
Yeah, we now have it's now 11:24 on my end. It's on my end. So you have about half an hour.
Okay.
More than half an hour. But we were dedicating about 25 to half an hour for questions and answers. But I think the cases might probably stimulate the questions.
Sure.
Because I'm not seeing any questions at all as yet.
Okay, hopefully people have not fallen asleep. All right. So what I'm going to do, I'm going to show either a case study or a picture, and people should tell me in the chat or so, what is the sign? what is the stage, what is the incubation period. After I show the picture, I'll show this again, so you don't need to make a note of this. And what serological tests we would be doing, and what type, and what would be the treatment for her and treatment for her partner or partners. All right, so here's a picture. So you need to tell me, what sign is that? Show the picture again. Well, that's the picture of a female genitalia, and it's a chancre in the inner aspect of the, what's that, left labia, circular, circumscribed, clean base. Can't really say if that's rolled edges. So that would be a case of chancre, right? So that's the sign, a chancre, and the stage would be primary syphilis, and incubation period would be 9 to 90 days. Well, let's just flip to that side. This would what it would be, a chancre, and it's good to tell you where it is. We would have the primary syphilis, incubation period anywhere 9 to 90 days. So mommy might have got it before pregnancy or during pregnancy. And serological test to be done, whether you're doing your trust or your RPR or VDL, whatever non-treponemal test you're doing, it would also be good to do a treponemal test. And the treponemal test is likely to be reactive. Remember, that's the test that becomes reactive first. And the non-trep, if it is reactive, in some instances in primary syphilis, that may not be reactive, but if it is reactive, it's usually much higher than 8, 1 in 8, or yeah. And her treatment, just one injection. Just one injection would treat her for this, because that's early infectious syphilis, primary. And her partner or their treatment would be the same, just one injection, even if their test is non-reactive. So we would want to get the partner. Any infectious syphilis, we must try to do some kind of partner notification referral system, because that is how we're going to control syphilis. Yes, we can control this EMTCT, but if we still have that pool out there, it's going to make our EMTCT efforts very difficult. So we have to mop up the pool of syphilis out in the population. And one way is definitely partner notification and referral. So if this partner comes in, and earlier the better, and we test him, we must test him, we must examine him too, because he could be an index case, or one of them could be an index case. And so we need to examine them properly, do their test. If their test is non-reactive, we still treat, because they're their contact to an infectious, highly infectious disease. So we call that epidemiologic treatment. And so we will treat partners of if despite them being non-reactive for any stage of infectious syphilis. And what about her baby? If she was treated within 4 weeks of delivery. So she came with that chancre, and she came at, say, 32 weeks, and she got her treatment the same day, 32 weeks, but she actually delivered 3 weeks later. So this sometimes 4 weeks of delivery doesn't necessarily mean a full gestation age, right? Because they may have had premature labor and so on. So if she was treated within the 4 weeks of the delivery, then we need to treat the baby. We need to examine the baby for congenital syphilis and do the investigation and treat with our IVIM Crispen and IV Crispen or IM procaine pen. And even if the baby is non-treponemal or treponemal test was non-reactive, or even if it was lower than mother's titer. So even the mommy was, say, 8, and then, well, if she was chancre, she probably would be a reactive 32. And then she got her treatment. And when do we test mommy? A month after. Well, she probably would not have been able to be tested after, because she delivered within the 4 weeks. So we wouldn't have a second result, but we have the 32, and we'll test the baby. And if the baby was 8 or 4, then that's not an infection per se, but we are not taking a chance. It's possible that she could, so we would treat and examine and treat the baby. What if the baby was she was treated more than 4 weeks before delivery. So 32 weeks she came, but she delivered at 40 weeks. We did our repeat test during a month after, and it came from 32 to 4. Then it looks like there is no reinfection there before or at delivery. And mama got her BPG. So what they're suggesting is, like we said, if adequately treated, there's a possibility that you could give benzathine penicillin 50,000 units IM per kilogram to the baby, especially if you're not sure the return visit. Okay, but you want to repeat testing and visits during visits for the routine vaccination, and you repeat tests of mom when she come at postnatal and so on. And what if she presented like this with this ulcer at delivery, no prenatal care? We would have to treat mom, but we would have to treat baby as well. Case 2, same thing. Can you tell me the sign, stage, incubation period, and so on? This is a 25-year-old TJ presented to the prenatal clinic. Her history includes 2 male sex contacts in the last 3 months. She can't get pregnant again. And she used condoms sometimes, or that might be her income. And her HIV and syphilis tests noted in her file 3 years ago were negative. On examination, the only abnormal finding is a moderate frothy discharge. And today, her treponemal point of care test, if you are using that algorithm, is reactive. So, what is her sign? What is her stage? What is her incubation period? I prefer last week's group. I mean, the last time group was very interactive. I think people are busy
Very,
today.
yes.
Or
Very.
is football? Which football match is happening? Anyways, you see the case, so there's none. If we examine, there's no sign for syphilis. She had a moderate discharge, frothy, so that might be that she has trichomonas. And that's another thing. If you have on examination, your risk history may not have suggested something, but you see an STI, you also think of possible syphilis as well, okay? Or you do a test and so on. So her stage would be late latent, because she had had a non-reactive syphilis test more than 2 years ago. And that's why we would call it so-called incubation period, not really because she doesn't have any sign. And we would have done a treponemal test, which was reactive, as they said, and we would do her non-treponemal test, whether it's a RPR or a VDRL, or a trust, whatever our non-treponemal test you're using, and her titer would be usually less than 1 in 8 because it's late latent. So maybe reactive 1 in 2, reactive 1 in 1, or 1 in 4, or even reactive 1 in 8. Treatment would be for her to get the benzathine penicillin G 2.4 mega units weekly for 3 weeks. And what about her partners? Well, this time it's late latent. Remember, we said late latent is not infectious, not so infectious. So we would bring in the partners, test them, check for signs, and if they have no signs and they're non-reactive, we don't need to treat them, right? Unless there's something in the history, very high risk or so. And if no signs and reactive, then we have to treat that person for late latent too. So sometimes the partners themselves become index cases. Case study 3 too, same thing. This one is going to be a case 2. And so this one is a 30-year-old pregnant woman, DS, attending her first antenatal visit at 36 weeks. You know, one of those? Because it's her third pregnancy. She now knows everything about delivery and pregnancy. And so that's sometimes the challenge with our health literacy for our women, especially pregnant women. They need to really understand how important it is to come as early as possible so that they can have their test done and so that if anything is abnormal, they can be corrected. So her file indicated a history of syphilis and treatment. And so probably that's why she's not even coming again. She knows that they're going to just give her injection and she knows she doesn't have syphilis, or so she thinks. So her first pregnancy in 2017, when she came at 22 weeks because she was, new to this thing. So that's why she came at that time. Her treponemal test was reactive. Her non-treponemal test was reactive, 1 in 4. And so at that time, the doctor said, okay, this is, I guess, latent syphilis, so we will treat with 3 injections. Hopefully, doctor examined properly. But anyway, reactive 1 in 4 sounds more like latent too. And we noticed that her repeat test, when she came out postnatal clinic, we say that that result was reactive 1 in 1. So went down from 1 in 4 to 1 in 1. Then her second pregnancy, 34 weeks, at in 2022, she's reactive and reactive 1 in 2. She's given stat. The diagnosis written is just syphilis. He didn't see any result in postnatal time or any review. And remember, we're not just to review at postnatal, we are to follow up the mother, as how any non-pregnant person with syphilis, you would do a test in 3 months, then 6 months, and so on, depending on until when it's non-reactive or low titer that stays. So this time now she's at 36 weeks. She's still 1 in 2. What do we do? That's rhyming. So what's her sign? What's her stage? What's her incubation period? So again, we say maybe there's none if they examine properly. But she also may be somebody who did not get to be examined properly because she came pretty late in pregnancy. She may also have come pretty late that day when she was coming to the clinic, and so maybe was not able to get examined and so on. So these are the mothers that we are to look out for. Those who don't have prenatal care, those who are coming in head-on perineum and so on, or these challenges, mental health challenges, homelessness, and so on. We need to be very careful and sometimes offer empiric treatment because that's how we're going to help to prevent congenital syphilis in many of these. So her stage is that she's not infected. She's adequately treated. I'm going to go back to the case if possible. Because you see, she went from reactive 1 in 4 and was adequately treated for her stage and went down to 1 in 1. The second pregnancy went to 1 in 2. 1 in 1 to 1 in 2 using the same test is not a 4-fold rise. So we wouldn't have said she got reinfected in her second pregnancy. But following the WHO recommendation, PAHO recommendation, we'd have given her a stat dose. So maybe the diagnosis was syphilis serological test positive and not really that she has syphilis, right? It comes again, the titer is still 1 in 2. So this is why I'm proposing that maybe she is really serofast, all right? I would be very astute in following up her because even from the history of not coming for antenatal care and so on, that alone in itself is sort of a risk and maybe a broader risk in terms of, other health literacy and chance risk that she would be taking. So I would be careful to say serologic, to say serofast, but and not to just follow her. So her treatment is that she would be getting the benzathine penicillin stat dose, and that's what we call empiric. So she's likely serofast, but we're giving her that stat dose just in case she was serofast and now got infected in this pregnancy. Remember, syphilis infection doesn't cause any immunity, so you can get reinfection. So she could had latent and in this pregnancy was exposed to another infection of syphilis and so may not have mounted as yet. So it's always better to just give a stat dose to the baby. Suggest to give a stat dose to the baby. And for the partners, if they have no signs and they're non-reactive, then we don't treat. And if they have no signs and reactive, then we would treat as latent and give 3 injections. Okay. So the serofast patient is one with documented evidence of adequate treatment for the stage of syphilis at that time, but with a persistent low titer. And what the recommendation is that she should receive a stat treatment of benzathine penicillin G with each new pregnancy. As long as she is reactive, she should have a stat dose. And we do follow-up test monthly, treat only a fourfold increase in titer, right? And the treatment, if we see fourfold increase in titer, then she's infectious syphilis. It's early, so one treatment would one stat would also cure that, would be the treatment. So the greatest risk for congenital syphilis is really a lack of proper antenatal care. And even beyond that, it's a lot of the social issues and so on, the determinants of health that are some of the risk factors for congenital syphilis. Well, we don't have much time to talk about, but I know that you can ponder on this and you can even examine in your locale and see what are some of the more important risk factors for your locale. So they say, elimination of mother-to-child transmission of syphilis starts even before pregnancy, right? So your comprehensive family planning services, if they're not pregnant and don't want to be pregnant, then they won't have syphilis in pregnancy. They may have syphilis, and so we still have to have our syphilis control programs. You want to make sure that she comes early and complete antenatal care, that she is completeness of case reporting and follow-up of care. We fall in that regard a lot. And complete care before, during, and after delivery. And we know that all mothers should have at least 2 serological tests for syphilis in the pregnancy. When she comes in, and if she's there for 3rd trimester, we also, and even sometimes at delivery, depending on the risk. Sometimes you may even have a mother that you have to test every month because of that risk. She may be homeless, on the road, exposed to, sexual abuse and so on. So we may need to be testing her every month because they can become syphilis infection any stage during the pregnancy. And the later in the pregnancy, more the risk. We need to check the mother, make sure that the mother is not discharged from hospital if we don't have a serological status for her. And we need to get the serological status of the baby. Do not use the cord blood. The cord blood is there. Blood is just coming from the placenta, but you will actually be contaminating. Some of the blood may be coming from the mother, some come from the water and jelly, and it's very difficult. You don't know if it's truly baby's blood or not. So it's just, you have to take blood from the baby, even if it's a stillbirth, and or have the serological test for the mother, and to document and report HIV and syphilis. Okay. So just to note that you have guidelines, the WHO PAHO guidelines, EMTCT+, that's the framework, but they have given us framework for countries to develop their guidelines. So this is just a picture of the one for Jamaica. And usually your stakeholders within your country who, like your pediatricians and so on, will help you to also create your guidelines. So congenital syphilis surveillance, we notify all infants born to serological mothers who have a syphilis test positive, basically. Syphilis test for serological test for syphilis reactive mothers, all right, or seropositive syphilis mothers. All of them, we must notify all infants. Remember, congenital syphilis is a class 1 disease. You report it on suspicion. So all infants born to untreated or inadequately treated mothers, so either not treated for the syphilis at all, or not treated properly for the stage, or not treated early enough, then we need to, those infants would be called congenital syphilis surveillance cases. Born to mothers who were treated, but treated in less than 30 days. Okay, I also had said that too, but specifically we have to call that one out. Or born to mothers who were treated with erythromycin. Or an asymptomatic infant, but the titer is at least 4 times that of the mother, of course, using the same serological test. And regardless of any result of that infant, if the infant has signs in keeping with congenital syphilis, we're going to notify that infant as well. So all of these will be deemed a case when reviewed for EMTCT certification or recertification. And by the way, all infants born means born alive or dead. So we need to have to remember to also include stillborn in our surveillance. In fact, this is a good practice too, that whenever you're doing a routine history, if there's any history of any miscarriages or, stillborn or so, make sure you have a test of syphilis for that woman, whether she's pregnant or not. That's how we're also getting to pick up cases. And we shared the impact indicator, so we know that that's what we're going to be looking for, trying to have less than 50 cases per 100,000 live births. So key steps in the management of syphilis is that we want to maximize case detection by screening when indicated. Not only our pregnant women, in our STI patients, in our persons who have high-risk sex, in our and that's why we also do screening for medicals and so on. So that's a good thing. Sometimes we pick up those, but often those are late. So we want to try to pick up cases earlier, because it's the early cases that are very infectious that are causing the epidemic to grow. Maintain high index of suspicion for all anogenital lesions, generalized rash, or high-risk sexual activity. I tell you, this generalized rash will fool many, will fool dermatologists, will fool expert clinicians. So it's a good practice. Generalized rash, do a syphilis test. And remember, co-infection with other STI. They like company. Syphilis like company. Gonorrhea likes company. So if they come with any STI, you want to test for syphilis. Conduct partner referral services, as I mentioned before, very important. Provide appropriate treatment to index cases and the contacts, and follow up treated patients to ensure adequate response. We fall on that as well too. So sometimes the person is back in the pool because they are reinfected, because we may have had some partner notification, but we did not get all the partners. And so that person in that network is now reinfecting the network. So it's really, really important to follow up the patient. That's how we're also going to be able to control syphilis. Encourage behaviors, of course, that will prevent reinfections, and put in place things that will help to encourage to prevent reinfection. No use with saying use condoms and they can't get condoms or they don't have access. So, other things, we need to ensure that we do the things that will enable them. So some key points: syphilis in pregnancy is definitely preventable and treatable. So we can eliminate congenital syphilis. And penicillin remains the gold standard for both mother and infant, and even non-pregnant persons. Penicillin is the gold standard. It is a wonderful drug. Give thanks. There is no resistance, and that it was discovered. It really is, and it works for persons with HIV or not. It is a wonderful drug. Respect it, protect it. Early detection and treatment prevent congenital syphilis. There's no vaccine for syphilis yet, let's say, but the prevention relies on screening and treatment. And it's the compassionate care, the people side, that gets people in and for them to be treated. Because remember, the stigma with syphilis is still very high. In fact, we have reports of that in Jamaica, where the mothers were treated, but when they reached to the hospital, they take off that part, the letter that they were given to say that they were treated because of that stigma. And so, if we have stigma there, it's going to be hard sometimes it's going to make our elimination harder. So a confidential service too, or, person's confidentiality is also perceived or not. So it is, even though you may be confidential, if they perceive that you're not, then, so you have to go to extents to even try to make sure the perception is there of, it's a confidential service, but it's also the persons will have that perception. And it's comprehensive care. Elimination is not only for the midwives or for the HIV program or so. It's really for an integrated approach. We need our dentists, we need our midwives, we need our community health workers, we need our hospital persons to be more aware. It's really everybody needs to be on board. Our pediatricians certainly are some of our partners, oftentimes so at the late stage. So we know it's hard, we know you're committed, and we want you to say, press along, saints is what we have. So you want to, because usually eliminating means that you're trying to find the hard to find. You have already done the easy ones, low-hanging fruits, and now it's the harder ones. So we know that it's rough. But eliminate the disease, not the persons or the program. So we also encourage you to, be good to yourself so that you can be healthy to serve, and that we're not, just because our cases are going down, that we know put on shelf, put up all of our tools and strategies that we use. We don't want to eliminate, because things will come back. So that's it for now, folks, and some references there. And I thank you for your attention. Hay preguntas?
I am not seeing any, I'm not seeing any. Are you hearing me?
Yes, I'm hearing.
Okay, I'm not seeing any questions in the chat or the Q&A. I think this might be a sign that the presentation was well delivered and very, very impactful.
Or they,
But
or they
I've
got
been
to ask
looking.
their questions last time.
Yes, maybe,
Well,
maybe.
well,
Oh, but somebody,
this would still be
okay,
there to refer to,
yeah.
so that's good, yeah.
But somebody, I think I should say, somebody saying, thank you, Dr. Hylton-Kong. That was a great presentation. So maybe it is that they really received the information that they had been looking for. And I know you did address in your presentation the questions and feedback I shared with you in the evaluation.
One of the
Yes,
things, the
people are
discordant
saying, yeah,
results, we went through that, I think.
yes, yes,
There was something about we went through that, refusal of testing. No, let me
yeah.
just probably address that, because refusal of
Yes, because
testing, or,
we still have 8 minutes.
oh, I'm sorry, I didn't even, how was there going on? Because we do have persons who will refuse testing or who will refuse treatment. And one of the principles of anything that we do is a human rights-based approach. So we cannot force anyone. We
Mhm.
can counsel and advise and try to, because we have to make sure that they're informed. And it's not just saying something, it's making sure that they understand and so on. So our approach is really important. It's never mandatory. It's opt out, but even that process. So, but if the person, I was saying, like, for example, this person who was serofast, she maybe says she's a mother who came on time and so on. She knows, she has studied Google and she knows that she's serofast. She may say, no, 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 I am not infected with syphilis. I do not want an injection. And she has that right. You just make a note in the file, let her sign. So your documentation is going to be important. If PAHO is coming now to recertify or so, they see that documentation, they can't do anything. You have done your best. And so the documentation is important. But I would say you wouldn't just leave it there. If you're the midwife there, you need to make sure your supervisor knows about this case. So maybe somebody else will try to counsel her. In other words, this is something that needs to be escalated, so that in other words, we did our very best to try to get this person to understand that this is needed. And we have that too. Sometimes it's the partner who doesn't get treated, and so they get reinfected and so on. That can also be very challenging.
Well, I am still not seeing any question except congratulations and so on. Thanks for the great presentation. And so that's all I'm seeing coming in, things like that. So, on behalf of Sandra, I really want to thank you, Dr. Hylton-Kong, and to extend my sincere thanks for your excellent presentations, both the one that you did um, last month and this one. They were very clear, well structured, and delivered with a level of professionalism and depth that the participants, by their comments, truly, truly appreciated. I think your ability to break down complex information and guide the group through the material made a very significant impact. And while I'm telling you this, I'm seeing A question, can inadequate treatment lead to reinfection?
Certainly, certainly. If they're inadequately treated, then the syphilis is still there. And so they can then, maybe in that case, if they did not have sex, that is persistent because it's still there. So I would call that persistent, but it can cause reinfection in a partner and so on. Yes. Thanks for that
So
question.
great. So the feedback received so far really reflects a deep appreciation for the clarity, the relevance, and the practical value of your sessions. It is very evident that your preparation and thoughtful approach contributed greatly to the success of the training. So
Well,
we want
thanks
to
for your
thank you.
concept notes too,
Yeah.
and the feedback you got from the person. So that helped.
Yes, yes. So we want to thank you again very, very much. I want to say to the participants, because people are asking for the presentation, and so all of this, there's an ongoing project now to bring all of this data, all of the information, the presentations, it's being developed in an observatory, so that you would hear more about this, so that people will have access to all of the information, the presentations, all the questions, and so that people ask the recordings. All of that is going to be placed in this observatory for your access. So you can look out for that. Look out also for the next presentation. You will hear more about it, and what the topic is going to be. Today didn't seem to be a very good time for a number of you because some have been busy. I see that, people are stating in the chat, that it wasn't a good time for one or two persons who perhaps doing clinics and so on. But you will not lose out. You're going to have access to this invaluable information that was provided by Dr. Hylton-Kong. So once again, thank you very much. Thank you, participants. Today, it's interesting though that today, I don't know what's happening in the Caribbean today, if there's a holiday, but today the participation, the number of persons who participated wasn't the usual, close to 200 over, today we just had something like, let me just see how many people we have here. Just under 40, I think, persons participated today. So so I'm hoping that at the next session, people will, get back in gear and participate. So thank you again, everyone. Have a wonderful weekend. Some of you have a holiday tomorrow. Please enjoy and be safe. Thank you again, Dr. Hylton-Kong. I think you're muted in case you were saying anything. I see you muted. Okay. All right. Take care.